Good day, everyone. So today I will be talking about atelectasis. In this topic, the objectives are to learn the definition, the types, the etiology, the clinical features, the pathophysiology, the diagnosis, the treatment or managements, and in addition, atelectasis versus pneumonia on radiography. Now, what is atelectasis? Atelectasis is a loss of lung volume caused by inadequate expansion of the air spaces, collapse. It results in shunting of inadequately oxygenated blood from pulmonary arteries into veins, thus giving rise to a ventilation perfusion imbalance and hypoxia. Atelectasis refers either to incomplete expansion of the lungs, neonatal atelectasis, collapse of previously inflated lung producing areas of relatively airless pulmonary parenchyma, acquired atelectasis. Airway collapse may involve all or part of a lung. Atelectasis is one of the most common findings seen on a chest X-ray because a lot of radiology is about pattern recognition. For the pathophysiology, atelectasis may occur in adults as a result of reduced ventilation, the non-obstructive atelectasis, or any blockage that obstructs passage of air to and from the alveoli, the obstructive atelectasis, thus reducing alveolar ventilation. Obstructive atelectasis is the most common type and results from reabsorption of gas, which is a trapped alveolar air is absorbed into the bloodstream. No additional air can enter into the alveoli because of the blockage. As a result, the affected portion of the lung becomes airless and the alveoli collapse. Causes of atelectasis include foreign body, tumor or growth in an airway, altered breathing patterns, retained secretions, pain, alterations in small airway function, prolonged supine positioning, increased abdominal pressure, reduced lung volumes due to musculoskeletal or neurologic disorders, restrictive defects, and specific surgical procedures. Patients are at high risk for atelectasis post-operatively because of several factors. A monotonous low tidal breathing pattern may cause small airway closure and alveolar collapse. This can result from the effects of anesthesia or analgesic agents, supine positioning, splinting of the chest wall because of pain, or abdominal distension. Secretion retention, airway obstruction, and an impaired cough reflex may also occur, or patients may be reluctant to cough because of pain. This figure shows the mechanisms and consequences of acute atelectasis in post-operative patients. Atelectasis resulting from bronchial obstruction by secretions may also occur in patients with impaired cough mechanisms, as well as in those who are debilitated and bedridden. In addition, atelectasis may develop because of excessive pressure on the lung tissue, which restricts normal lung expansion on inspiration. Such pressure can be produced by fluid accumulating within the pleural space, air in the pleural space, or blood in the pleural space. The pleural space is the area between the parietal and the visceral pleura. Pressure may also be produced by a pericardium distended with fluid, tumor growth within the thorax, or an elevated diaphragm. On the basis of underlying mechanism and the distribution of alveolar collapse, atelectasis is classified into three forms. First is the resorption atelectasis, or the obstructive or absorptive. Airway obstruction causes the loss of pre-existing air in the peripheral alveoli, leading to alveolar collapse. It occurs when an obstruction prevents air from reaching distal airways. And since the lung volume is diminished, mediastinum shifts toward the atelectatic lung. It is caused by an obstruction of a bronchus by excessive secretions of the mucus or mucopurulent plugs or exudates within smaller bronchi due to: first is surgery, diminished respiratory movement resulting from post-operative pain. Second is foreign body aspiration, which is particularly in children. Third is bronchial asthma. Fourth is bronchiectasis. Fifth is chronic bronchitis. And lastly is the intrabronchial tumor, a centrally located bronchogenic carcinoma, which is a first sign of malignancy. For the pathogenesis, airway obstruction by thick secretions prevents air from reaching the alveoli. Airway obstruction occurs in the bronchi, segmental bronchi, or terminal bronchioles or TBs. After obstruction, the circulating blood in the pulmonary capillaries absorbs the pre-existing air in the peripheral alveoli, leading to alveolar collapse and an airless state within a few hours. For the clinical findings, most common are: first, fever, but not related to infection. Second is dyspnea, a difficulty with breathing within the first 24 to 36 hours after surgery. Absence of breath sounds and vocal vibratory sensation or tactile firmitus. Next is the dullness to percussion. The second form or type of atelectasis is the compression atelectasis. It is a collapse of small airways and alveoli deep to the pleura that occurs when air or fluid in the pleural cavity is under increased pressure. It results whenever significant volumes of fluid, the transudate or exudates of blood, tumor, or air in the pneumothorax accumulate within the pleural cavity. It is when mediastinum shifts away from the affected lung. Examples are tension pneumothorax, in which increased air pressure compresses the lung; large pleural effusion, which is usually in the setting of congestive heart failure, in which increased fluid compresses the lung; and basal atelectasis, resulting from a failure to breathe deeply, commonly occurs in bedridden patients, in patients with ascites, and during and after surgery. The third form or type of atelectasis is the contraction atelectasis. It occurs when focal or generalized pulmonary or pleural fibrosis prevents full lung expansion. Except in cases caused by contraction, atelectasis is a reversible disorder. Note: patchy atelectasis may result from loss of pulmonary surfactant, which is seen in hyaline membrane disease of the newborn. The fourth form or type of atelectasis is the round atelectasis. It is a combination of cicatrization and the compressive atelectasis. It occurs in patients with underlying pleural disease such as asbestos exposure or possibly a pleural effusion. Pleural effusion causes adjacent compressive atelectasis. The visceral pleura folds in on itself and then pulls the adjacent lung in due to surrounding fibrous adhesions. As the effusion shrinks, the compressed lung remains trapped while the surrounding lung aerates. The right middle lobe syndrome. Atelectasis is due to obstruction of the bronchus to the right middle lobe. An external compression by hilar lymph nodes. Bronchus is susceptible to external compression. Histologically, the lung shows bronchiectasis, chronic bronchitis and bronchiolitis, lymphoid hyperplasia, abscess formation, and dense fibrosis. Acute and organizing pneumonia may both be present. Tuberculous lymphadenitis or metastatic lung cancer may cause the lymph node enlargement. Cause of the obstruction is often undetermined. Another form or type of atelectasis is subsegmental atelectasis. It is a most commonly seen types of atelectasis on a chest X-ray. It is also called plate-like or discoid atelectasis. It results in linear opacities which often abut the pleura. It is a cause of collapse of the air spaces that are smaller than a single bronchopulmonary segment. Causes are hypoventilation, bronchial secretions, asthma, aspiration, or obstruction. It is also seen in patients who present with abdominal pain. For the assessment and diagnostic findings, when clinically significant atelectasis develops, it is generally characterized by increased work of breathing and hypoxemia. Decreased breath sounds and crackles are heard over the affected area. A chest X-ray may suggest a diagnosis of atelectasis before clinical symptoms appear. The X-ray may reveal patchy infiltrates or consolidated areas. Depending on the degree of hypoxemia, pulse oximetry may demonstrate a low saturation of hemoglobin with oxygen or a lower than normal partial pressure of arterial oxygen. Breathing enhances lung expansion, decreases the potential for airway closure, and may generate a cough. Secretion management techniques include directed cough, suctioning, aerosol nebulizer treatments followed by chest physiotherapy, and bronchoscopy. In some settings, a pressurized metered dose inhaler is used to dispense a bronchodilator rather than an aerosol nebulizer. Another for the chest X-ray, since the atelectasis has very sharp margins, it usually displaces the fissures, mediastinal structures, and hemidiaphragm towards the side of atelectasis. It can involve any portion of the lung, and it ranges from the entire lung to just a very small subsegmental portion. Now let's talk about the radiographic patterns in different lobar atelectasis. From the right upper lobe atelectasis or collapse, there is a shift of the minor fissure superiorly, a shift of trachea towards the side of collapse, and the S sign of Golden, which is due to hilar mass causing obstruction of the bronchus. From the right middle lobe atelectasis or collapse, it silhouettes the right heart border on the frontal view. There is an elevation of the diaphragm, and the density overlying the heart on the lateral view. From the right lower lobe atelectasis or collapse, there is a shift of the major fissure down, shift of heart to the right, elevation of right hemidiaphragm, silhouetting of the right hemidiaphragm, and density seen posterior to heart on lateral view. From the left upper lobe atelectasis or collapse, there is a hazy density around left hilum, elevation of the left hemidiaphragm, shift of mediastinal structures to left, lateral view demonstrates linear density posterior to the sternum, hyperlucent crescentic appearance surrounding the aortic knob, a Luffichel sign. From the left lower lobe atelectasis or collapse, there is a density behind the heart on the frontal view, shift of the major fissure down, silhouetting of the left hemidiaphragm, and the density posteriorly on the lateral view. Now we'll go to the treatment. Atelectasis should be treated promptly to prevent hypoxemia and superimposed infection of the collapsed lung. Management focuses on underlying cause and includes the manual chest physiotherapy, the mechanical insufflation or exsufflation, mechanically assisted cough, the intrapulmonary percussive ventilation, intermittent positive pressure breathing, and lastly is the surgery. which is for severe compressive atelectasis. The goal of the treatment is to improve ventilation and remove secretions. Strategies to prevent atelectasis, which include frequent turning, early ambulation, long volume expansion maneuvers, and coughing, also serve as the first-line measures to minimize or treat atelectasis by improving ventilation. Multidisciplinary, evidence-based standardized intervention programs such as the ICOF hold promise in preventing atelectasis. In patients who do not respond to first-line measures or who cannot perform deep breathing exercises, other treatments such as positive end expiratory pressure, which is a simple mask and one-way valve system that provides varying amounts of expiratory resistance, usually 10 to 15 centimeter. Continuous positive airway breathing or bronchoscopy may be used. Before initiating more complex, costly, and labor-intensive therapies, the nurse should ask several questions. These questions are: has the patient been given an adequate trial of deep breathing exercises? Has the patient received adequate education, supervision, and coaching to carry out the deep breathing exercises? And have other factors been evaluated that may impair ventilation or prevent a good patient effort, such as lack of turning, mobilization, excessive pain, and excessive sedation? For additional information, we will be talking about atelectasis versus pneumonia on radiography. So these are the differences between atelectasis and pneumonia. In atelectasis, it contains sharp borders, while pneumonia contains hazy borders. Atelectasis has no air bronchograms, while pneumonia has air bronchograms. There is volume loss and no volume loss. Both has silhouette sign and increased density. In atelectasis, there are rapid changes over time, while in pneumonia, there are slow changes over time. And those are the differences between atelectasis and pneumonia. And that brings us to the end. Thank you so much for your interest and attention. If you like this video, give it a thumbs up. You can also subscribe to this channel and click the notification bell to keep you updated for more educational videos. Again, thank you and have a good one.